Please, for 5 minutes.
There's private and public drug plans, right? And if you look at private plans like Blue Cross, Canada Life, Manual Life, they're all for-profit, run by for-profit companies. Is that right? Are any of them not for profit in the private sector?
Well, thank you for that question. That's a common misunderstanding. In fact, the majority of the companies operating in this space are not-for-profit. So Medavie would be a not-for-profit company. Green Shield, the Blue Crosses, Beneva. So they
Which ones are not for profit?
Well, all of the Blue Crosses across the country, Beneva, a large player in Quebec, Green Shield, all of them are not-for-profit. So if you look at the number of carriers in the country, probably about over half are actually not-for-profits. They reinvest everything they make back into their communities. And then there are certainly large players who are for profit as well. So it's a mix.
Do you know of employer plans, what percentage are non-for-profit and which percentage are for-profit?
Yeah, I don't have that number in front of me. I apologize.
So why would an employer not right away get a non-for-profit insurer?
You know, the for-profit companies provide a very compelling solution to clients, and so do the not-for-profits. A very competitive market. There's over 20 insurers that compete for business, and employers will make decisions based on what's best for them.
You think non-for-profit or for-profit insurers can provide the same sort of plan at the same cost as a non-for-profit one? Are they that competitive that you say, okay, because I would have thought like the concern with any private insurer in a private company that's a for-profit company then isn't a percentage of the employees what would otherwise be their benefits, their income, instead going to the profit of the corporation. And so, like, why would anyone, unless they can be that efficient that they actually provide the service cheaper than a non-for-profit, why would anyone have a for-profit insurer?
You know, that's a case by case. You'd have to look at the situation of each employer and what they're looking for in their benefit plan. But it is a very competitive space. Many of these, the majority are not-for-profits, as I mentioned. And I think you can infer that the profit that's being made in this space is quite low, even for the for-profit companies. So it's important, very important. We offer incredible value to Canadians. We're very proud of that. And as an industry, we compete really hard to make sure we're doing the best that we can for them and ensuring that they have the ability to access what they're entitled to.
Can I assume that for-profit companies would argue that they provide a broader set, better coverage than the non-for-profit ones?
I don't think you could make that general statement, no. I think it's an extremely competitive space. Everyone's competing with a very broad suite, and employers make decisions based on what's in their best interest. So it's a case by case, hundreds of thousands of employers out there who have different reasons for going with different providers.
So an employer has to basically buy a plan for their employees, right? And in the case of for-profits, what percentage of the money that goes towards that plan ends up in profits? You've said it's small.
It's very small. Again, I don't have that detail in front of me, but what I can say is that it's a mixed system, for-profits and profits competing aggressively. The thing that unites them is that we provide coverage for 27 million Canadians. All of them get much better coverage than they would on any public program. And we're very proud of the service that we offer to Canadians. And we also know that overwhelmingly, they don't want that disrupted.
I'm going to sound like someone in Peter Julian's party here when I say this, but why would you enter? Why you as a company, as an insurer, would want to enter the business if your margins are so small? I mean, why form such a company? I mean, I'm being a bit skeptical of the fact that you're saying, oh well, you know, they hardly make any money at all. Well, I don't think many companies have that kind of mindset as when you're a corporate executive with those companies.
Well, it's a business that's important to us. It's a very competitive business. Margins are low. And we're competing every day to offer the best service that we can for Canadians. And I'll just reiterate, the 27 million Canadians who have those coverages today do not want to lose it. And so I think as the government contemplates its go-forward plan with pharmacare, what the minister was talking about today makes a lot of sense. That's not what's reflected in this legislation. And so I do think amendments need to make sure that that maps to what we heard this morning from the minister. And I think we would work very closely with the government to try and target the solutions to those who need it and to leave what working well in place today.
Thank you, Mr. Frank. Monsieur Blanchette-Chonka pour 2 minutes et demie.
2.5 minutes. Yes, I would like to follow up on my questions with Mr. Frank. In Quebec, the pharmacare plan has been in place for 30 years, and we hope that others in Canada will follow suit if they find it a good model. There is an amount that people pay, a user fee, but I would like to know, there is a deductible. So if we eliminate the deductible and have the first dollar payment, how can that really work? What I can say is that we think that Quebec's system works quite well, and it could be a model for other jurisdictions in Canada. We agree with you. The public and private sectors work together to provide exceptional coverage for Quebecers. I can't speculate on how it could work within this bill. It isn't clear. As I mentioned, the terms aren't clear, but one of the big risks in this legislation is that people can come to different conclusions when they read it. I think that it needs to be reviewed and amended so that it is clearer. The system in Quebec does work very well, and that. Thank you for recognizing Quebec's expertise. You work in this field. What area of Canada has the best plan? Every area is different, but I can say that Quebec has a very good system. It has a partnership between the public and private sectors and provides universal coverage for all Quebecers. It's a very good system. Could you also give us the opinion on who is going to be deciding on these drugs? Is it going to be the Canadian Drug Agency or INES? We know how it works with INES in Quebec, and we would have the Canadian Drug Agency elsewhere. We don't recommend any changes. It seems to be working well. INES works very closely with the federal government on this, so it works. It is a question, though, about as to who will decide what is covered, and the coverage changes, how frequently they will take place, and so on. Thank you.
Round of questions for this panel will come from Mr. Julian for 2.5 minutes.
Merci beaucoup, Monsieur le Président. Mais là, il faut.
Thank you, Mr. Chairman. We will have to repeat this because some people in Quebec may not be aware. There is a coalition representing 2 million Quebecers. We have the health professionals, the community and volunteer, the CST, the CNSN, big unions. In their brief, these organizations have indicated again that the Quebec pharmacare plan does not provide fair and universal coverage. The various costs to people that they have to pay when they get drugs are problematic. They are a sort of user fee, and so people ration their medication as a result. Given that the Quebec private-public system doesn't work according to over 2 million Quebecers, what is the conclusion when we have people saying, oh, everything is fine and we should stick with what we have instead of having a federal plan.
I think that fine for who is what we've got to talk about. Is it fine for Canadians? Clearly, we hear people in Quebec are not happy with the system that they've got. If you talk to one of the leading health economists, Steve Morgan from the University of British Columbia, he's run the numbers. He says that Quebec is paying for drug medication as one of the highest jurisdictions in the world. In fact, per capita, they're only topped by the United States. They pay more than Switzerland. So, and in fact, if that system in Quebec were translated to other provinces, costs would actually increase because of the problems in the system. And so I think that I take the word from experts, from economists, health economists, to say that look at the Quebec model very closely, listen to what people are saying. Is that the system that we want to have for the rest of the country? Or do we want to go with the kind of single-payer national universal system that's envisioned in Bill C-64?
Thank you, Mr. Julian. Thank you, Mr. Staples. And thank you to all of our witnesses for being with us today. Certainly a great variety and diversity of expertise, all of which is valued and appreciated. Thank you so much for being with us. We're going to suspend until 7 o'clock to allow for this panel to take their leave and to get the next panel installed. The meeting is suspended. Inc., Celeste Thériault, Executive Director, and from the Society of Obstetricians and Gynecologists of Canada, Dr. Diane Francoeur, the Chief Executive Officer. You're probably aware that opening statements are 5 minutes in the order listed on the notice of meeting, so we're going to begin with opening statements now, starting with the Canadian Pharmacists Association. Ms. Walker, welcome to the committee. You have the floor.
Monsieur le Président.
Mr. Chairman, ladies and gentlemen, members of the committee, thank you. We're very pleased to have this opportunity to share our views with you tonight on Bill C-64. I'll be giving my remarks in English, but I'll be pleased to answer your question in French or English.
Tonight is really aimed at providing the committee with a very practical perspective on what could happen at the pharmacy counter as changes are contemplated and considered as part of the legislation. And my testimony will focus on 3 points and 3 points only. The first is really around the role of pharmacists in pharmacare. As anyone who's used a prescription drug will know, pharmacists are the last person that the patient will see before they get their medications. And while the act of dispensing is complex, pharmacists do a lot more than simply fill and sell medications. They provide critical care and counseling that are integral to the effective use of medications. Their daily interactions with patients place them in a unique position to understand their needs, educate them on proper medication use, and advise on potential drug interactions. And pharmacare really should be about more than just the cost of the drugs, but rather the care that goes along with them. Pharmacists also play a significant role in drug plan management and navigation, and that's not often seen by many patients. Every day, they submit millions of claims on behalf of their patients. They spend time on the phone with insurance plans, and they help patients identify alternative treatment options that are covered by their plans. It's for this reason that it's essential that we have a pharmacist on the government's proposed committee of experts. The second point I'd like to make is around the best target to target medication coverage. Contraceptive and diabetes medication are two very important drug classes, and there's no doubt about that. There's also no doubt that there's too many people in Canada that don't have access to these drugs for cost-related reasons. However, the focus of Bill C-64, which aims to provide free contraception and diabetes medications to all Canadians, irrespective of their existing coverage, could warrant reconsideration. The intent of reducing the burden of these drugs is the right one, but our view is that the projected cost of over $1 billion could provide even more comprehensive coverage if directed towards expanding coverage for a broader range of medications for those who currently lack adequate coverage, rather than replacing coverage for those with existing drug plans. We believe that such an approach would be more feasible, fit better with the needs of provinces, and limit disruptions, all while ensuring universal coverage for all. And that brings me to my third and last point. While change is sorely needed to ensure universal pharmacare, the potential for significant disruption can't be overstated. And as members of this committee can likely attest from the recent PSHCP or Public Service Healthcare Plan changes, changing drug plans can be very disruptive for plan members and for pharmacists. Switching patients from a private drug plan to a public drug plan can be equally disruptive, so changes must be implemented carefully to avoid confusion and reduce administrative burden. The reality is public drug plans across Canada are far less comprehensive than private plans, which means that if the legislation shifts patients from their private plans to their public plans, pharmacists and physicians will likely have to spend a considerable amount of time switching patients to new therapies, especially if their drug is no longer covered under a public plan, filling out paperwork to get special exemptions, and communicating these changes with patients. And if I can, I'd like to provide maybe a personal example in conclusion. I'm on a birth control pill that is not on the current list that's been proposed by the federal government, and it took me 3 years to find the pill that worked for me and that didn't have side effects that I, lived with daily as a woman. This raised some very real questions for me when I looked at the intent of the bill. Will my employer continue to cover contraceptives if that's not covered? I'll certainly lobby for it, but it's definitely a question in my mind. Will my pharmacy continue to stock products that aren't broadly covered? And if there are exemptions, will my pharmacist have to apply for that exemption on my behalf, as they often do with many drug plans? So I hope this was able to give you a sense of frontline issues that could arise, and I thank you and welcome your questions. Merci.
Thank you, Ms. Walker. Next, representing the Heart and Stroke Foundation of Canada, Mr. Arango.
Thank you very much. Heart and Stroke applauds the Government of Canada and Parliament for introducing Bill 64, which will lay the groundwork for equal access for life-saving drugs for all. People in Canada appreciate our universal healthcare system, but the reality is Canada is the only country with Medicare that does not include prescription drugs as part of its universal healthcare program. The current patchwork of public-private plans in Canada has created fragmented drug access, leaving millions struggling to afford their prescription medications. I don't think there's any disagreement with this. While many people in Canada have some sort of form of drug coverage, it is often insufficient and poses affordability issues. So the 2019 Hoskins report indicated very clearly that 7.5 million people in Canada had either no coverage or insufficient drug coverage. As well, the 2021 survey on access to healthcare and pharmaceuticals during the pandemic found once again that 1 in 5 people did not have insurance to cover any of the cost of their prescription medications in the previous year. Furthermore, a poll commissioned by Heart and Stroke and the Canadian Cancer Society in 2024 found that 1 in 5 people in Canada do not have sufficient drug coverage. 1 in 4 had difficulty and had to make difficult choices to afford prescription drugs, such as cutting back on groceries, delaying paying rent, mortgage, or utility bills, and incurring debt. Furthermore, the same poll found that 1 in 10 in Canada diagnosed with a chronic health condition were more likely to visit the ER due to a worsening health issue because they were not able to afford their prescription medications. A study in 2016 also found that 16% of people in Canada went without medication for heart disease, cholesterol, and high blood pressure because of cost. With the introduction of this bill, the foundation is being laid for the first phase of national universal pharmacare through single purchaser coverage of diabetes and contraceptive medications. ultimately providing equal drug coverage for all people in Canada, regardless of their gender, race, geography, age, or ability to pay. But we do feel that this needs to be expanded in the future to cover drugs such as heart disease and stroke. The reality is that millions of people in Canada live with heart disease and rely on daily prescription medicines to help keep them alive and to manage their condition at home. In fact, in 2022, 105 million prescriptions were dispensed for cardiovascular diseases, making it the second highest disease category. Universal coverage of essential medicines will reduce pressure on the health system by cutting costs. Because treating a condition such as high blood pressure, which is a leading risk factor for stroke, is more cost effective for our healthcare system than the specialized care required to save a life after a stroke. Heart and Stroke has made a number of recommendations for amendments in our submission, but I'd just like to highlight one today, and it pertains to Section 8, parentheses 1, regarding a national formulary. And we recommend that there should be a definition inserted here for essential medicines. In particular, essential prescription drugs should initially be defined as those included in the Clean Meds trial. That's one way to define essential medicines. We feel that the government must take quick action to close the gap in coverage that leaves out essential medicines for chronic diseases, including heart disease and stroke, that affect many in Canada. We also recommend that the minister prioritize the signing of bilateral agreements with provinces, territories, in tandem with the progression of the bill, and to pass this bill before the House adjourns for the summer. Finally, I would like to address some other key points and misinformation about pharmacare. The reality is that the federal government, as a single drug purchaser, would be able to negotiate much lower prices compared to the myriad of private and public plans. And this would have a significant deflationary impact on the average drug price. So we heard comments earlier on about bulk purchasing, and it's a very well-known business in the world of business procurement, that a company that buys 100,000 widgets from a manufacturer is going to get a much better price per widget than a company that buys 5 widgets per year from the manufacturer. So the reality of bulk purchasing and the fact that it leads to lower prices, it's well known throughout the world. In New Zealand and Australia, with respect to drug purchasing, and even just in general, if you look at Costco, bulk purchasing there leads to lower prices. So a national pharmacare program will not. Another point too, as well, is the notion that coverage is going to be decreased through pharmacare, a national pharmacare program. And in fact, it's going to be the opposite. We're going to get enhanced coverage. The reality is that we have 7.5 million people that don't have coverage or inadequate coverage. The objective is to increase coverage for those people. So it's just not a reality that we're going to get reduced coverage. If the government, the federal payer, is covering a diabetes generic drug, if that's in the private plan or in the public plan or in the federal plan, it doesn't matter. One way or another, it's going to get covered through one of those 3 ways. So I don't foresee reduction in potential coverage. It's the opposite. We're aiming for the opposite. So to conclude, Heart and Stroke applauds the federal government and Parliament for the introduction of this legislation, proposing an affordable plan that will give 7.5 million uninsured and underinsured people access to prescription drugs for diabetes and contraception. We really hope that in the future, this can be increased and expanded. As my colleague has mentioned, I think we do want an expansion of this formulary in the future. But this is a good start. And so thank you very much.
Thank you, Mr. Arango. Next, on behalf of the National Indigenous Diabetes Association, Celeste Theriault, welcome to the committee. You have the floor.
Thank you, Chair, and good evening, everyone. My name is Celeste Thériault, and I'm the Executive Director at the National Indigenous Diabetes Association that's located on Treaty 1 lands in Winnipeg, Manitoba. And it's an honor and real privilege to be speaking about this bill in front of you as it relates to Indigenous people in Canada. And a little bit about the National Indigenous Diabetes Association. We refer to ourselves as NIDA, and we're a charitable nonprofit members-led organization that was established in 1995 as a grassroots initiative for women on the side of Lake Winnipeg, advocating that diabetes was taking too much from their people. And that was almost 30 years ago. That's First Nations, Inuit, and Métis inclusive in Canada. And so this bill really provides the beginnings of a comprehensive pharmacare program for all Canadians and represents a significant step towards addressing social health inequities across Canada, including within Indigenous populations. Indigenous people, First Nations, Métis, and Inuit, and I may refer to them as a pan-Indigenous term, but representing that they are distinct nations with distinct interests, that they suffer disproportionately from the socioeconomic constraints and illnesses, as well as they stand to really benefit substantially from the provision of much-needed diabetes care, especially Métis individuals who are not covered under the current non-insured health benefits program. And so the current government of the day is really commended for this first step and including diabetes medication in that first step. That said, we should be continuing to do this in a good way. And what does that mean? That means talking with our Indigenous nations, political leaders, and individuals with lived experience to make sure that no one gets left behind. We know that changes that affect Indigenous people with Canada should be done with us. As we know, nothing about us without us. And I would like to mention that because of the short period of big decisions between the tabling of the bill and this consultation, we didn't have adequate time to consult all of our members of interest with the implications of the bill, and that our organization by no means can talk on behalf of all Indigenous nations across Canada. So there should be continuous and ongoing meaningful dialogue with many Indigenous people and nations, and especially our political leaders, and that the Minister of Health talks not only in terms of provincial and territorial governments, but also our Indigenous governments that have some sovereign rights to having their voice heard here on this legislation. So it's vital that we roll out this new program very carefully, that we really consider the context of existing benefits, particularly through the non-insured health benefits that present the right of the status First Nations and Inuit beneficiaries in Canada to provide for medications for treatment of diabetes and other pharmacological care, but not all of them. So it is at the detriment of the individual. It also remains unclear whether NIHB and the new Pan-Canadian Pharmacare program will be responsible for providing medication coverage to these individuals, but as the minister spoke earlier today, that all the programs would kind of remain in place, so we believe that that would be helpful. The coverage of medications for First Nations and Inuit can be bureaucratically burdensome, and we know this. Individuals and healthcare providers on reserve are already really administratively overwhelmed, so we need to ensure that the policy is reducing those burdens administratively so that our providers can directly impact patients and deliver patient care in a good way so that we don't need to burden individuals with getting their medications covered. We also want to make sure that there's a comprehensive list of medications allowing for both the prescriber and the patients to be advocates in the healthcare journey of their diabetes management. And of course that we want to steer away from a two-tiered healthcare system that, only the best and strongest medications are only available to those with deep pockets, with privilege and secure employment with strong health benefits. So in that same tone, we want to ensure that no Indigenous person is left behind, because having mid-cis individuals not including in the NIHB means that mid-cis individuals providing their care will have much greater access through this bill. And we have to remember that when we walk forward in this legislation. And we need to be at the bare minimum or equal at the bare minimum of equal or better than current coverage for all Indigenous people in Canada. And we must make sure that we are working together to ensure that there is that access, whether that is brand name medications for diabetes care when the generics are not available, again, supporting timely access and ease of use for Indigenous people so that, those living with diabetes can keep their healthy blood flowing now and several generations from now. And as a Indigenous woman, I'd be remiss of the opportunity to also comment on the contraceptives. As someone who had to use 3 IUDs to get my last one successfully put in, IUDs are quite expensive, and that would be not possible for me had I not had some support in place to be able to do that and make that a reality. And so that all Indigenous people are able to access whatever form of contraception they need to determine what is best for their own person, and that the funding should be provided for each of those types without exceptions, just as it should be with diabetes cares, as it's an extremely personal journey. So we look forward to a Canada where First Nations, Métis, and Inuit have equitable access to life-saving medications, although more consultation is required to move forward in a good way. We really invite further collaboration on this vital project to ensure that no one is left behind. We want to ensure that everyone from our Indigenous elders, youth, lived experience people, Indigenous nations, governments, and politicians are adequately involved in the decision-making process of this bill, not just, like I said, our provinces and territories. And let's continue to work together in a good way to ensure that we are raising health outcomes for all Indigenous people in Canada, representing a significant step forward in addressing social health inequities across Canada.
Ms. Thériault, please.
Merci. Thank you. Thank you for your attention.
Okay, thank you. Dr. Francoeur, representing the Society of Obstetricians and Gynecologists of Canada. Welcome. You have the floor.
Thank you. Mr. Chair, members of committee, bonsoir. My name is Dr. Diane Francoeur. I'm a practicing obstetrician and gynecology, as well as the Chief Executive Officer of the Society of Obstetricians and Gynecologists of Canada. I'm here today to discuss the aspect of Bill C-64 that proposed to offer universal coverage of a full range of contraceptives for Canadian women. Specifically, I wish to highlight why this measure is important and long overdue, why it's not just a woman issue or a nice-to-have measure, but a necessary economic policy that benefits all of society, and why we hope as legislator will ensure coverage of all forms of birth control are included in the final bill and that it passes without any undue delay. Today, somewhere in Canada, a woman will have to choose between buying grocery, paying her electrical bill, filling up her gas tank, or paying for her birth control. It's no secret the rising cost of almost all goods and services have become a significant burden for many Canadians. But 9 million women of childbearing age in Canada bear the additional cost of preventing unintended pregnancy, a basic need which often flies under the radar, but which is no less fundamental to the way of life of millions of Canadian women. Contraception allows women to plan their lives, their families, and their pregnancy. They are more likely to finish school, they participate more fully in the workforce, they enjoy more economic stability, and they have healthy pregnancy when they do choose to have children. Canadian women spend on average 30 years of their lives shouldering the associated cost of trying to avoid a pregnancy. But financial barriers can limit birth control options for many women, as you so highly said. Canada currently has a patchwork of coverage for contraceptive, which varies according to income and where you live. This forces some women to choose the cheapest method, not necessarily the most effective or the best method for their bodies. Or in some cases, they may not be able to afford any birth control at all. This can result in an unintended pregnancy. I see this every week in my practice. We can do better than that for Canadian women. Approximately 40% of pregnancies in Canada are still unintended. This don't just only impact women and their family, but it also affects the economy. The direct cost of unintended pregnancy in Canada is estimated to be at least $320 million per year, a figure that doesn't include the downstream cost to society or to parents. The BC modeling indicates that the health system will save $5 for every dollar they invest in contraception every year. As legislators, we urge you to ensure that Bill C-64 passes smoothly and without undue delay. To fully implement the commitments in this bill, Ottawa will need to negotiate agreements with the provinces and territories, which will take time. Any parliamentary holdup will only force women to wait longer for this much-needed assistance. Already, my patients, my neighbors, my nurses with who I practice every day have been asking me when this coverage will become available, because it's never soon enough for those in difficult economic situation. We also urge you to ensure that the final version of the bill and any budget measure attached to it include coverage of a full range of contraceptives, including the pill, the patch, the ring, the IUDs, the shot, the implant. By ensuring that all options are available, 9 million women in Canada will no longer be forced to make decisions about their family planning based on their income. Thank you.
We will now begin with rounds of questions, starting with the Conservatives for 6 minutes. Dr. Kitchen, please.
Thank you, Mr. Chair, and thank you, everybody, for being here at this late hour and on such short notice. It's greatly appreciated, and I think that's part of what Canadians want to see is true conversations and discussions of what this piece of legislation says and what this piece of legislation means, and being able to decipher it in a manner that the average person that might even be watching this evening at this point in time can understand what is going on and the challenges that we have. To you, Ms. Theriault, and thank you very much for your comments and your insight. One of the things in my past life, before I became a member of Parliament, I was a consultant for the FNIHB. And so I'm aware of things along the lines of providing healthcare services to First Nations in different avenues. I'm wondering if you could explain to those watching who don't understand, because FNHIB is covered by the Government of Canada. And so what you could say on the coverage for diabetes and other coverages that might be available?
Under the NIHB program, correct?
Correct.
Thank you, Mr. Chair, and I thank the constituent for his question. So the NIHB program and specific diabetes medication coverage is more extensive than the formulary list that was the backgrounder list that was circulated. And there are some disparities between the NIHB list and the Canadian practice guidelines that are published. And so they're not fulsome and not comprehensive in the first place if we really wanted to pick them apart, but they are better than the formulary list that was proposed here as a base minimum. And there are some that are only able to be covered if there are specific requirements of such. You need to be an insulin user to get a specific medication covered. So it varies in terms of all of the medications. One big one that we see that is not included is your GLP-1s, and that's something that our Indigenous people use extensively to manage their blood sugars in a way that works for them. And I think that we need to look at it very, very holistically on what it also provides outside of pharmacological care, because pharmacological care, sorry, that's a hard word for me today, is only a certain portion of what is covered under non-insured health benefits.
Thank you. So to be clear, you're basically saying that what's being proposed in this legislation is actually less than what is available for First Nations at this present time, under the understanding also that the services that are provided to First Nations are universal across Canada. They don't vary from province to province.
So first of all, it is for status First Nations and Inuit beneficiaries. So yes, for status First Nations and Inuit beneficiaries, the NIHB program currently provides more coverage. Now we are missing an entire other population of Indigenous people and also our non-status individuals within that scope. So we cannot make a sole judgment just based off that one thing, but yes.
I appreciate it. So are you, and granted you did touch on the fact that because of how quickly this came about, you weren't able to get conversations with all groups. Are you aware of whether actually the government has actually talked to First Nations about this before this piece of legislation came about?
I am not aware, and I wouldn't be privileged to that information in my current role and position.
Okay.
But I do make it clear that our Minister of Health does need to have those conversations.
And that was going to be my next question. Do you think that's an important aspect where this Minister of Health should be talking to our First Nations before we even get this out on the table?
I believe that our Minister of Health has to have conversations with provincial and territorials, as well as our First Nations, Inuit, and Métis, not just First Nations, governments, and that can be done in a good way through moving the bill forward, and also making sure that, I think the minister said today that he cannot have concrete conversations with the provincial and territorial governments, that he'd be in breach of Parliament or something along those lines. So we want to make sure that the Indigenous voice is heard first and foremost.
Thank you.
And I think everyone can work together towards that.
As you indicated, it should be also for the provinces and the territories to have those conversations.
Of course.
Thank you. So, Ms. Walker, and thank you very much, and I have huge respect for my pharmacists that I have my own personal pharmacist because of the advice that they provide. And a lot of Canadians don't understand the knowledge base that they have, and oftentimes they are much more knowledgeable on all medications, more so than perhaps even the doctor who's providing that information. And I don't mean that disrespectfully. It's just that that's what you spend 4 years studying to become that pharmacist. Your comment about the committee, and that I find one of the things that I find very discerning about this piece of legislation, because it doesn't clearly define what that committee will be. It doesn't say how many people will be on that committee. It doesn't say what their role will be, what qualifications they need to have in there. And so your comment about having a pharmacist on that in one manner, I think is very important. And I'm wondering if you could expand on that.
Absolutely. I mean, I think it's very natural to think of your pharmacist first and foremost as the person who's managing your medication treatments on an ongoing basis. And they really can provide a very practical, real-life view of what any changes would propose. So whether the legislation goes in any particular direction, the end result is it's going to be an interaction between the pharmacist and the patient at that counter, right? And so they need to be able to explain what the change has been, why the change has been made, and depending on how the spectrum of the changes that are considered, changing millions of people from different programs could be hugely challenging from just even a logistics and burden perspective. So having somebody like that on a committee would be essential.
Thank you, Ms. Walker. Next, Mr. Joe Harry, please, for 6 minutes.
Thank you, Mr. Chair, and thank you to witnesses for coming. Just want to follow up on what Dr. Kitchen talked about. Just want to also thank you for advocating for pharmacists. One of my very good friends, my mentors, and the one that I trust with all my medication is Akil Dirani, who's running many practices, and I often go to him for advice on many things, especially around the pharmacare. I'll ask you a very simple question. You are familiar with, or I believe you are familiar with the plan, the healthcare plan that we have, okay? And if I develop type 1 diabetes, what would be the scenario today for me? What would be the difference today, whereas tomorrow when this bill passes? What would it be when I go to Akil and say, Akil, now I have type 1 diabetes, but it's universally available now. What change would I see from a treatment? And what change should I anticipate from my insurance provider?
Yeah, so it really depends a little bit on the treatment that you're currently using. We certainly fielded an enormous number of questions from pharmacists when the PSHCP transition was made, because there were changes that affected patients. One of the biggest one was, as some members might be familiar, compliance packaging for elderly people. So that's a service that was provided with an understanding from the pharmacist and the physician that it was noted in the file. But now a pharmacist has to apply, or the patient has to apply, go into their paperwork, get a response back from the plan provider. And so I'm illustrating that just to mention that it can be additional processes to go through. And so the difference might be if you're on a drug that isn't currently envisioned on the list, such as the GLP-1, the question will be, will your current plan cover that and pick that up? We're also very familiar with the challenge that employers are looking to cut costs as part of their plans, right? So if it's already covered, if a drug class is already covered, they may look to reduce those costs so that they can invest in other areas of their plans. And so